Good evening. My name is Kate Kelly. I'm a family medicine physician and an addiction medicine fellow, soon to be attending at Metro Health Medical Center. It is the county safety net hospital of Cuyahoga County, which is where Cleveland is located and where I am currently. I am the committee chair of DFA's Committee Against Greed in Healthcare, and I'm also a member of DFA's board of directors. Our Committee of Greed Against Healthcare sits in our impact area of access to affordable care. So if any of you are interested in this type of topic, we have plenty of opportunities for people to volunteer. So before we get started, I want to take a quick minute of your time before we have our two amazing speakers to invite you to officially join Doctors for America. Being a Doctors for America member today means you're taking the important and simple step of selecting membership level and paying for your annual membership dues to support this type of work. Advocacy Grand Rounds is one of many programs we do for Doctors for America, and there are 4 different levels to choose from to become a member. There'll be a link in the chat about membership. Um, just a personal note about being a member of DFA. We do not take any money from pharma. We do not take any money from medical device companies. And we are truly one of the very few physician and other clinician organizations that are putting patients over politics. And I would also argue patients over profit. Being a member of Doctors for America has made my personal and clinical practice much better. I'm get to hang out with like-minded folks like our Representative Bowman and Dr. Berg on the call, as well as the many DFA members who really have made my life so much more rich. If these are issues you care about, if you get frustrated when you're on Epic or whatever other EMR you're using, if you get angry at the pharmacy benefit manager and you want to tear your hair out, DFA is the place for you. And we are open arms for anyone who wants to join, and we would love to have you. This will be live streamed on Facebook, and we'll be making recordings of all materials to be available afterwards. Just a couple ground rules before we get started. There's no such thing as a stupid question. There are no attendings on this call that will make you feel dumb. This is a place of love. And remember, when you're doing questions, use the Q&A feature. We will try to answer everyone's question in the last 15 to 20 minutes of this talk. And then look out for comments. DFA staff will be sharing helpful links to help move the session along. So tonight we're going to be discovering how greed and profiteering are corrupting healthcare in the US while we familiarize ourselves with the major issues around greed that clinicians face today. We'll also learn how to apply anti-greed principles in the state legislature and to advocate for policies that improve and access healthcare outcomes. I really like to take a couple minutes to introduce our two wonderful speakers. We are very, very fortunate to have Dr. Don Berwick, an Oregon State Legislature, Ben Bowman. Dr. Berwick is the leading scholar. He's also a teacher and advocate in the world for continual improvement of healthcare systems. He's a retired pediatrician and a longstanding member of the faculty of Harvard Medical School. He founded and led the Institute for Healthcare Improvement, now leading the global nonprofit organization in its field. Global nonprofit organization in its field. He was appointed by President Obama as administrator of the Centers for Medicare and Medicaid Services, where he served in 2010 and 2011. He's counseled governments, clinical leaders, and executives in dozens of nations. He is an elected member of the National Academy of Medicine and the American Philosophical Society. On a lesser known but extremely cool fact, for Don's work with the British National Health Service, in 2005, Her Majesty Queen Elizabeth II appointed him Honorary Knight Commander of the British Empire, the highest honor awarded by the UK to a non-British subject. And Don can tell you all about the corgis after the call. So just make sure to put that one in the chat. Representative Ben Bowman is a state representative for House District 25 and majority leader of the Oregon House of Representatives. He's also the director of student and family supports at Gladstone School District and co-founded the OR 360 Media. Before joining the legislature, Ben was the chair of the Teagar-Tualatin School Board and the Innovation and Partnership Strategist at the Oregon Department of Education. He graduated from the University of Oregon and earned a master's degree in education policy from Stanford University. And if you ask nicely, he might actually get you on the Oregon track, but I'm not making any promises. But we'll see how the seminar goes. So without further ado, I'm going to turn over to Representative Berwick. Maybe Representative Berwick, I don't know, Dr. Berwick and then Representative Bowman, and we'll save some time for questions at the end. So Dr. Burke, please go ahead and start us off.
Thanks so much, Kate. Thanks to DFA. It's an organization I care a lot about too. I think it's extraordinarily important piece of the landscape now in American healthcare and getting more important all the time. And Representative Bowman, it's an honor to join you on this platform. What I'm going to do is kind of set the stage. I hope for Representative Bowman's comments. I'm going to try to achieve two things. I'm going to try to just summarize for those of you who don't know, although I think that's very few of you, the kind of state of the system right now, what's going on in American healthcare, and then talk a bit about greed and its function as I see it. I will share some thoughts about what to do about it, but the bottom line, I'll spoiler alert, it's you've got to get active. This is a matter of political power, and physicians and other clinicians have a tremendous opportunity to be leaders in the political context against an awful lot of pressures in the other direction, but you got to do it. You can't just stand by. If we stand by, I think things are not going to go well. So let me just talk a bit about the healthcare system. Here, most of you might want to go grab a quick cup of coffee because you probably know all of this, but at the Passover Seder, you have to recite the 10 plagues, frogs and locusts and so forth. So sometimes when I review this now, I feel like I'm reciting the 10 plagues in healthcare. We're not performing as a nation with respect to the health and well-being of our public and with respect to the performance of the American healthcare workforce, healthcare system. That's not 100% the case. My own wife had her life saved a couple of years ago with open heart surgery that was done absolutely magnificently. And we have a lot of high-tech successes that I don't think should be on the negotiating table. We really want a high-performing technical healthcare system. But we're here to serve a public. Quality is the degree to which we're serving them correctly. And that includes not just healthcare delivery, but also health status. And by these metrics, general performance and health status, we're just not doing very well. We are ranked 69th in the world by an important nonprofit in the UK in the performance of our healthcare system, 69th, at double the cost of the next most expensive country, or almost double, which is Switzerland. Switzerland ranks second in the world in health system performance and health status at about half the price of the American healthcare per capita. Our longevity is about 40th in the world. Our infant mortality rate is about 40th in the world. We have growing areas of poor health in the population, tremendous problems with substance use disorder and behavioral health now. And by any objective metric, our country is being outperformed by most developed Western democracies by a long shot. And that is at double the cost of the average, Western democracy. It would be hard to imagine how, if you intended to construct an underperforming system, you could do so badly, because it's just not working for people. If you poll the public at large, as Gallup did just a couple of weeks ago, the public is upset. They like their doctors. They have a sense of affection for the system, but they are very troubled by costs, out-of-pocket costs, which are staggering for some families today. They're troubled by access. They can't get to the doctor or provider they want, and they're troubled by complexity. They don't understand this system. It's bewildering. I ran Medicare and Medicaid, and I must say I get communications all the time from the healthcare world that I don't understand. The costs in aggregate are going up very fast still. In Massachusetts, my state, we just passed this year $10,000 per person per year. For a family, we're spending more on healthcare than to buy a car every year. Patients and families are reeling under this underperformance. On the economic side, we have about 110 million Americans who are in medical debt right now, just about 1 in 3. No other country comes close to being able to make that claim. And medical debt is now, I believe, the first or second most common cause of bankruptcy in our country. Again, no other country gets to say that. We do. Um, the From the public health point of view, we're living with not just overall problems in health status, like our average longevity, but also tremendous inequities. If you go from the Chicago Loop, a relatively wealthy part of Chicago, to West Chicago by, I don't know, 3-4 miles, you lose 16 years of life expectancy. In Flint, Michigan, it's 15 years from rich to poor parts of Flint. In my city, Boston, it's over 20 years of life expectancy lost in just a few miles. That's because health and well-being are not just created by healthcare, they're created by the circumstances of our society, the way we treat young children, the way we treat our education systems, the strength of our workplace structures, our reaching out to elders who are vulnerable, and infrastructures in communities, transportation, food security, housing security, criminal justice, environmental exposures, and on and on. So in order for a country to be healthy, and we are not by comparison to other Western democracies, we lag the healthiest country in the world by about, I think it's about 7 years of life expectancy. Those healthy countries are investing in the generators of health. So they secure really good circumstances for early childhood. They invest heavily in equitable and excellent education for everybody. They protect workers, not just with good salaries, but with protections in the workplace that help workers thrive. They protect elders by working against loneliness and isolation. And they protect community infrastructures by investing in transportation and housing and food security. They have very different criminal justice systems from ours. We incarcerate more people than any other per capita than any other country except Russia. And the circumstances that bring people into contact with the criminal justice system are often health matters. 70% of people in prisons and jails have substance misuse or behavioral health disorders. Other countries appear to be behaving smarter than that. And as a result, they have much higher general health status. Their health systems perform more reliably across the board, and they cost us a ton less. So why? How did this smart, capable, wealthy country get into this condition? And the consequences of being there range way outside healthcare. I mentioned the effects on families, but ask Representative Bowman what it's like to put together the budget for his state. If you look in any public or private budgetary system, healthcare is eating opportunity. I call it confiscating opportunities, because if it could function better at a lower cost, what entitles us to deny resources in state and federal government, for example, or in employer activities to other uses? Why are we there? Okay, I don't really know. I think it's highly multifactorial. It's historical. The causal system is difficult. Just running a hospital is a hard job. I mean, this is a risky, vulnerable system of care. We get pounded by a pandemic that we just didn't see coming, or most didn't see coming, and the workforce ends up back on its heels. So there's a lot of things we could talk about. The thing that I've been noticing more and more, though, is I'll make the general statement that money runs healthcare. Money has been the central focus of much too much of healthcare, corporate medicine in many guises. The patient and patient conditions and the health of the public have become secondary to the pursuit of profit. I want to be careful here because it's a complex system with many players, and there are counterexamples to everything I'm telling you. And I honestly believe, naive though it sounds, that most of the people that I accuse of profiteering in their hearts, they're not evil. They have just gotten trapped in a cycle of incentive and national structures that make them behave the way they behave. Uh, Even well-intended get swept up in this pursuit of profit as what's driving them. Insurers, a complex system that I think overall I've come to believe doesn't add value. Now, my insurance friends will push back on that. They'll show me counterexamples. But I think the most of the big insurers, and there are 5 large insurers that dominate this country in health insurance. What are they investing in? Well, in Medicare Advantage, which is a massive part of the healthcare insurance industry, they're investing in upcoding patients so they can make more revenue, pre-authorization games, denial games, delays of access, playing the float. And they are doing very well, thank you. United Health Group has now become, I think, one of the five largest corporations in America, not 5 largest healthcare corporations, all corporations. They pay their CEO last year $23 million of compensation. They're constantly talking to their investors and stockholders about maneuvers they're making to increase revenues by stock buybacks. They're good people in United, but I don't think that's a company that regards its mission as restoring health and well-being in our country and reducing costs without harming a hair in anyone's head. I think they are serving the investor community. It's always amused me when I was heading Medicare, Medicaid. My job was partly implementing the Affordable Care Act. About 70% of the Affordable Care Act fell under my office, and we were implementing the medical loss ratio restrictions, which says you can't spend less than 85% of your premium dollar on healthcare. You can use 15% for other stuff, profit, advertising, administrative structures, but 85 cents on the dollar has to go into care. And the insurers screamed like we were somehow taking something away that they were entitled to. And the rating companies, the bond rating companies would score insurance companies in such a way that the lower the medical loss ratio, the lower percent of the premium dollar you spent on healthcare, the more healthy you were. How crazy is that? That we score as financially healthy to collect premium dollars and not spend them on care. The pharmaceutical industry is almost famous or notorious now for what it's doing with pricing. They claim it's necessary for innovation. I don't think so. I don't think the data support that. And what we do know is that the lack of discipline in pharmaceutical pricing is denying people access to drugs they need and taking a lot of money out of the treasury, both public and private. Hospitals, important places, saving lives, like my own personal story. We need healthy, robust hospitals, but in this whole pathological system, they're being forced into playing games that are hurting the public interest. Market consolidation and raising prices that claim that they'll save money by consolidating. That's not what happens. As you may know, the Department of Justice just appointed a new commission to study what's happening with market consolidation and private equity in healthcare. Rich hospitals, both for-profit and not-for-profit, are withdrawing from underserved areas in embarrassing ways. The governance of hospitals is financial. 2 medical students of mine at Harvard did a study of 15 large health systems and found that 14.7% of their board members were clinicians of any type. 85% were real estate moguls, private equity people, big businessmen. Now, these are people who care about healthcare. They wouldn't be on boards if they weren't, but they don't know about healthcare. So we're being governed by people who regard financial success as success. The more recent story that's kind of hit the press is private equity. Private equity now owns 10% of American hospitals. They own a much larger percent of nursing homes in America. They own 95% of autism care in the United States. Private equity are firms that pool money and buy stuff that could make them money, whether that is making candy bars or soap or healthcare. That it's not substantively invested in the mission of care that reflects the oath I took when I became a doctor. We now know that thanks to the research of Zuri Song at Harvard, when private equity buys a hospital, according to Zuri's measurement, there's a 24% increase in adverse patient events, certain kinds of infections and falls, for example. Nursing home mortality after private equity buyout goes up 10%, costs go up 11%. And in the autism sphere, what happens is that they use a cookie cutter care processes for autistic kids, which you can't do. Every autistic kid needs a highly customized plan. Here in Massachusetts, we had the implosion of the private equity firm Steward Health. Um, had bought now 30 hospitals around the country. They just went bankrupt and leaving people high and dry while the executives of Steward Health with tens of millions, hundreds in some cases of millions of dollars of investment yielding. Um, how can we stop it? Well, I don't know, because in the United States, money, concentrated wealth, generates a political access and power, which then blocks attempts to put restraints on concentration, on wealth concentration. It's a vicious cycle that's really hard to break. And it's bipartisan. I experienced this when I was running Medicare and Medicaid. The phone calls I got, don't mess with my local hospital, came from both sides of the aisle. I think this is not a stable situation. The total costs of care in the country are rising steadily and unsustainably. The morale of the healthcare workforce is been seriously damaged, not just by this dynamic, but by many things that are going on. And now more and more physicians are finding themselves employees of large financial entities, and the damage is ongoing. I could talk more about this, but I think I'll stop here, just having laid it out. But with the what I think is the big idea, the only idea I can come up with, especially in this context, is clinicians, not just doctors, nurses, therapists of all types. I think we need to get politically active and engaged at a level we have not yet done, except when we're lobbying for more money. The AMA does that, but lobbying for a set of public policy initiatives which restrict greed and acquisitiveness and profiteering in healthcare is essential, and physicians can make that happen. DFA is a big voice. It can get much bigger. You have many partners in the clinical world that want to join in. One of my dreams now at this old stage of my life is to try to form a coalition even bigger than DFA, where clinicians start to say, no, no, the patient comes first, not profit, not money, not corporate greed, not salaries for insurance executives, not bottom lines on operating statements and bulging balance sheets. We need to readdress this. I can get to more specifics, but I'll stop here and turn you over to an expert on policy, someone that really can help us think through that a little more. So thank you, Representative Bowman.
Awesome. Thank you, Dr. Berwick. I will say that I did not feel qualified to be a panelist on a Zoom with you before I knew that you were an honorary Knight Commander of the British Empire. And so now that feeling has only been magnified. So I'm Ben Bowman, state representative out of Oregon, and I want to build off of what Dr. Berwick discussed a little bit by using a case study of what happened in Oregon in the last legislative session. So, given the dynamic of the healthcare ecosystem that Dr. Berwick laid out, I think there are a few tools that we can use to regulate the system, protect patients and physicians and other providers from corporate greed, and sort of restore, I think, a sense of morality into the healthcare system. One of those potential mechanisms is called the corporate practice of medicine doctrine. Some of you may be familiar with this. And I'll preface by saying I'll probably get some of these details wrong and ask Dr. Berwick to correct me when I finish here. But corporate practice of medicine doctrine has been around for a very long time in this country, almost 100 years. It exists in like 40 plus states. And basically, the principle of CPOM is that physicians and advanced care providers should be the ones in charge of patient care and clinical practices. That's the fundamental belief of CPOM. These are uncontroversial laws. Republicans support them. Democrats support them. No one you're going to hear that I've heard is saying we should get rid of these laws. They're sort of accepted as part of the regulatory framework. In Oregon, what these regulations actually mean in practice is that 51% or more of every medical clinic has to be owned by physicians. Okay, 51% ownership. Some states have a 100% requirement. In Oregon, it's a 51% requirement. So that's one set of facts that's relevant. At the same time that this regulation exists, there is a massive increase happening across this country and in Oregon of private investment into the ownership of healthcare clinics. Private equity is a giant actor in this space, but also large multinational, multi-billion-dollar corporations like United Healthcare, like CVS, like Walmart, like Amazon, are increasingly investing in owning medical practices. So if you're like me, you hear these two sets of facts and you say, okay, wait a minute. On one hand, physicians have to own these practices. And on the other hand, you're telling me that corporations and private equity firms are increasingly buying these practices. Isn't that illegal? Here's what I have come to understand in the last couple of years. Yes, it is illegal for a corporation or a private equity firm to purchase a clinic that's supposed to be owned by physicians. But what they have figured out how to do is essentially circumvent corporate practice of medicine laws through a series of loopholes or workarounds that invert the intended relationship between managing a clinic and physicians and, in this case, a corporation. So basically the way it works is on paper, when you read about a takeover by Optum or a takeover from Amazon or CVS, what has actually happened is that on paper, there is an owner who is a physician of these clinics. That physician owner may not live in the state. They may have never visited the clinic. They definitely don't have to work in the clinic, but on paper, they qualify as the owner of the clinic. And then through what's called a management services agreement, the sort of ownership control of major facets of deciding how the organization is going to function basically gets signed over to this corporate backer or this PE-based MSO, they call the management service organization. So in practice, they're technically following the law. It's owned by a physician, but in practice, PE or a big corporation is deciding major aspects of how a clinic is run. Things like how much time does a doctor get to spend with their patient? Are we going to take Medicaid patients or not? You heard a little bit about upcoding. There's all these sort of things that you can do when you take over a clinic to maximize the amount of money you can make. And it almost always comes at the expense of patient care or physician independence. So the question is then, okay, so what do we do about this? What we tried to do in Oregon was essentially restore the corporate practice of medicine doctrine as an actual regulatory framework that means something, and assert that physicians and other advanced care providers have to be in charge of these clinics. That doesn't mean we didn't say no PE allowed. We didn't say corporations aren't allowed to invest. We just said at least 51% of every clinic has to be controlled by a physician or advanced care provider. Why is that important? Dr. Berwick sort of gave this explanation, and here's how I think about it. A PE firm or large corporation has a fiduciary duty to maximize the return for their shareholders. That is their job. That's why they exist. They exist to generate profit for their shareholders. That's not bad. That's not good. That is just a fact. That is what their job is. Physicians and other advanced care providers have a different duty. Many of them own businesses. When they own their own clinics, they have to make enough money to survive as a business and pay their employees. But they also have an ethical duty to take care of their patients. That is not an ethical duty that PE firms are bound by. That's why the CPOM doctrine as a framework makes so much sense to me, because it ensures that the people who have a moral and ethical obligation to their patients are actually in charge of patient care. So that was the framework. We introduced this bill. Most people, it was during what we call our short session. So it was a 32-day session. Very, very fast. It means like you have 1 week to move your bill out of committee, then one more week to move it off the House floor, then one more week to move it off the Senate committee. And it just is sort of a sprint. To the surprise of most onlookers, I think, we met the first deadline, passed it out of the House Healthcare with bipartisan support, Republicans and Democrats, moved it off the House floor with broad bipartisan support, moved it out of the Senate Healthcare Committee with bipartisan support. And then on the last day of session, the bill died without coming to a vote on the House floor. Uh, and I will tell you, we had enough votes to pass the bill. I had a Republican chief sponsor in the Senate, and all Senate Democrats had indicated to me that they supported the bill. So what happened? As you can imagine, Dr. Berwick alluded to this. There's a lot of money at stake in these kinds of decisions. And when there's money, there's political power. And where there's political power, there are lobbyists, people who are paid to advocate for the perspective and the interests of an organization. And many of these impacted organizations hired people with the explicit instructions and job of killing the bill or amending the bill or changing the bill or slowing the bill down, being an obstacle. And the reason why I tell you all that is because I actually think that there is a way to pass laws like this and other regulation that will sort of at least slow the negative impacts of greed, if not turn around the incentive system. And the only way it happens is if physicians and nurses and PAs show up in the legislature and they call their representatives and they get organized, as I think, Dr. Berwick, it sounds like you're trying to build a place where there can be a unified voice about what the people who are in charge of patient care actually think should happen. And here's why that's so important. In Oregon, I'll use Oregon as an example. We've got 60 representatives and 30 senators. We are what we call a citizen legislature. All of us have other jobs, or we're retired, or some of us are independently wealthy. I wish I fell in that category. So most of us have our expertise in other things. They're business owners. I work in a school district. We've got attorneys. Healthcare policy in this country is incredibly complex. Very few people understand how the system actually works. The same is true for legislators. The way it works is most legislators have like one or two committees or policy areas that they focus on. Could be natural resources, could be higher education, could be early childhood, whatever it may be. There's a very small group who actually focus on healthcare, but healthcare is a big topic. So even within the healthcare experts, there are very few people who understand all the different components of how the system works. When physicians show up to meet with the legislator or set up an appointment with the legislator, legislators make an implicit assumption that that physician knows and understands more about the healthcare system and what's best for patients than they do. That is just an inescapable reality. Whether it's true or not, whether you're an expert in health policy or not, as a physician, with those letters after your name, there is a sense of credibility that comes with that. And that credibility, especially when organized in large numbers, is enough, in my opinion, to counteract the political power of the corporations and private equity firms who have an interest in maintaining the status quo. The challenge then is, how do you organize a large group of physicians who are not the easiest group of people to organize? And how do you get that group of people engaged and pointed in the same direction? And that's the work that we have tried to do in Oregon. There's a few physician leaders in Oregon. Actually, there's a long tradition of physician leaders in Oregon. Dr. John Kitzhaber is a former 3-term governor of our state. He helped pass this bill right up until it got killed at the end. Dr. Bruce Goldberg is a former head of our state healthcare agency. Basically, we engaged him. And there's a group of young physicians. Dr. Tony German is one of them, who's a leader on health policy in the state of Oregon. And they've started to build out an infrastructure of doctors basically saying the system isn't working and we need to build safeguards to protect patients and to protect physician independence. And we're hoping to build a sort of advocacy arm of physicians and nurses and PAs who can counterbalance the weight of lobbying and special interest groups who will be encouraging folks not to change things, not to institute a new corporate practice of medicine regulation, not to eliminate non-competes that handcuff doctors. So that's our theory of the case, and that's why I think this organization is so interesting and useful, and other efforts from physicians across the country, I find very energizing because I think there is some movement right now. I think there is a growing sense of awareness and excitement about organizing advanced care providers to really stand up for themselves and their patients. And I think once we start building some momentum at the state level, which is where candidly I think all the action is going to be in healthcare policy for the next decade, I think there's an exciting opportunity to build on that momentum and carry the work forward. So it's an honor to be on the Zoom, and I'm interested in the questions or where we want to take the conversation from here.
Wonderful, thank you. Gosh, I just feel so energized just listening to both of you. So I'm just so grateful that you have taken the time to speak to our group. And I know a lot of folks on the call are just nodding their heads, even though we can't see them. So we are going to start with the question and answer. So if you have any questions, please put them in the chat. We'll try to get to everything we can. Um, the first question is from Don Leiter. Hi, Don. I haven't seen you in a while, but thanks for joining. The first one's for Dr. Berwick. What are those initiatives to limit greed? We generally hear of initiatives with no specifics, and how would they change the system? Now, and then there's one for both of you. So go ahead, Don, to answer the first one.
Okay, well, thanks for the question. I think you're exactly right. Talking about the problem is the same as defining the targets. You heard one from Representative Bowman about an initiative in the legislature trying to get meaningful corporate practice of medicine restrictions. I endorse that. I think it's a good direction to go. But we need a list that includes that, but goes beyond it. Some of the things that I'm interested in right now has to do with legislation to restrict the unhelpful behaviors of Medicare Advantage plans. Dr. Ed Weisbart is on this call. He's been putting together terrific materials explaining the game that Medicare Advantage works under. If we want to have some private insurers in the Medicare space, I guess we can continue to try it, but it's a pretty big failure right now, transferring over $80 billion a year from public to private coffers. There, we could have legislation on pre-authorization restrictions and rules, legislation on denials, and especially transparency around denials, delays in payment. Transparency overall is a good area to go into, requiring much more light to be shed on the behaviors of these entities, private equity and Medicare Advantage, and insurers overall, and hospitals. I think a bold move would be to move towards not-for-profit medicine. Not-for-profits sometimes are not behaving well at all, but overall, if you want to pick a direction in this country, the ability to earn extremely large profits in the care system, it does not look wise. It hurts patients, and it transfers money. I think generating that list would be really helpful, and it's a good project for DFA to do that. There is a petition underway in DFA against greed that Jim Scott and Ken Frisoff have been sort of leading on, and I think we should say a bit about that because that's a small act you can take. I want to emphasize what Representative Bowman said about doctors in state legislatures. We have a wonderful story that's played out in New Jersey, where three doctors, Dr. Tina Shah, Kedar Mate, and Nisha Mehta, they decided to focus, I think it was on pre-authorization. I don't remember if it was that or surprise billing, but they actually did exactly what Representative Bowman's talking about. They mobilized physicians in New Jersey to go to the legislature to explain and teach and talk about these bad behaviors, and they got a bill passed. And it would not have passed if the docs had not showed up and earned the trust and attention of the legislators. I'll make one final comment, and then sorry for carrying on. We do see this very interesting move toward unionization of healthcare workers. I think it's got some potential, but I've got a weird view of it, which is, okay, unionize if you want, but don't do it to earn more money. Don't do it to protect the incomes of physicians or other clinicians. Let that happen elsewhere. What if we took the power of unions and began to make demands supported by strikes for changes in the behaviors of designated parties in the healthcare world within states, I think it's time to speak up and stand up. That's where I'm headed.
Great. And we're going to put in the chat the Declaration Against Greed that Don alluded to. We have been working in our anti-greed committee to talk about our principles and talk about how we envision a healthcare system that is against greed and how we want to be part of that. And so please forward that, sign it. We have almost 500 signatures right now, and we hope it will be growing. So look out in the chat, and we would love you to sign that and share that. We can talk about that a little bit later. Just shifting a little bit, for a question, as this is an anonymous attendee, says, I work as a hospitalist in a nonprofit hospital and have risen the prestigious middle management role. How can I help my institution reorient away from greed? Or is my time better spent with Doctors for America and the lobbying legislature? I would say yes, but I'll leave it to Representative Bowman and Don to kind of go with that.
Well, you can imagine my bias, which is you should spend time in the legislature and explain to policymakers what's going on. You know, the prestigious middle management is quite the description. I'm skeptical that the people who are actually calling the shots at a large multi-million-dollar institution are going to be swayed by a single voice within their system. I hope I'm wrong. And I don't think you should necessarily discount that as a possibility. I think you should do what you can internally to try to help with that. But again, it's a nonprofit hospital, and nonprofit hospitals, at least in my state, often behave a lot like a for-profit hospital might. And so I don't know, Dr. Berwick, you probably got a better perspective on this question than I do. I'm interested what you think.
I totally empathize with the person asking the question. And yes, I would say spend your time with DFA and with lobbying legislatures, but it's not an either or. Inside the institution, I would organize like-minded physicians and try to get, I think the direction to go is to get more patient voice into the decisional processes. Work with your leadership to get patients on your board, to get patients into every process that leadership is doing, and keep talking about it. Bring your own patients in, speak up. The voice of people who actually have had experience, they will be grateful. They'll be worshipful maybe of the hospital, but they'll also say, these are the things that are going wrong in my life. So that's one direction you could go. Hopefully you will be going from prestigious middle manager to prestigious executive. And when that happens, walk the talk. You have to be demonstrating in your time, your attention, what you think the organization should be caring about. But my answer is all of the above. It's time for doing everything you can do.
Thanks. And Howard Eisenson has a question that I also wanted to ask, and we've been talking a lot about within our own committee. He says it's not just pharma, insurers, device manufacturers, and hospitals that demonstrate greed. If we are honest, it is also an issue that we providers need to confront as far as our own behaviors. The medical pie won't be enlarged, so reducing excessive costs will mean that some specialists, more than others, will need to forfeit some of their largesse, and some, especially in primary care, may actually do better. This notion that reform is likely to limit the income of some specialists make it difficult for physicians to come together and present a unified voice in favor of reform. How do we get past that? And just as a side to that, we at DFA, especially in this anti-green healthcare committee, do believe physicians are part of the problem, and we believe because of that we need to be a part of the solution. And so, Representative Bowman and Dr. Berwick, any ideas of how you can advocate some of our more affluent members of our medical community to support this work would be greatly appreciated as we move forward, not only as folks on this call, but also as an organization.
Dr. Berwick, you want to go first?
Thanks. The way in which the status quo wins is by dividing and conquering, teaching us that we are each other's enemies instead of noticing that the problems we share the problems in common. So this is a very difficult matter that Dr. Eisenson is raising. It will not be easy to redistribute physician incomes toward primary care, which is where I think it needs to go. And all I can say is, if we are not together on that, then the ship will sink for everybody. These costs are not sustainable. But I'm not naive about what it's like to have this conversation. If you go to the landing page of the American Medical Association website, they celebrate two major achievements in 2023. Number one is protecting physician incomes, and number two is preventing the expansion of practice for non-physician clinicians. That's not going to get us where we need to go. So I might turn to the state medical society, if it could be done, and say, can we develop leadership here for a true reform of healthcare instead of just acting like a guild to protect our incomes? But I can't say I have an easy answer to this difficult question.
I am not a physician and don't have much to add other than I do think that the medical associations are the venue where it has to take place, and it has to be leadership from physicians. I don't think policymakers or any other sort of regulatory body is going to be the one that does this. I think physicians have to demonstrate leadership and bring solutions. But what I do think policymakers are going to increasingly start trying to figure out is how do we pay primary care providers more? Because that is an increasingly large problem especially in states like Oregon that have a large rural population. We really need more primary care docs.
I think one of the areas of policy that we all might want to talk more about is moving away from the fee-for-service payment system, which is our enemy in solving this problem. I've only ever worked in a salaried practice, and I never would want to work in any other way. I had no incentive to do things that were not necessary and no disincentive to do things, not to do things that were needed. The specialist got paid more than I did, but I think if we could move toward, I'm a primary care pediatrician, if we could move toward consolidate global budgets and really probably to the extent possible salaried practice, we can get our attention back where it needs to be, which is on patients. That's why we're here.
Kind of piggybacking on that, Donald Leiter also said in his question, what about value-based care? Will there be price control by shifting risks to providers if we move to value-based care, which I think is what is the buzzword, right now is the solution to these type of RVU-based practices.
I'll start, Representative Bowman. So it's funny, I just came from a meeting, an all-day meeting today in Washington on this very matter for part of it. Who could be against value-based care? That we should, I guess that means we should do for people what's really valuable to them and not waste their time or ours or money or ours. So at some level, yeah, sure. Problem is that in the public debate, this whole term value-based care, in my opinion, has lost its meaning. It means so many different things to different people. I would, rather than try to parse that for Dr. Leiter, I would say we should go back to basics, which is we should have a payment environment in which the clinicians, the good clinicians, have the resources to where they're needed to take care of people. And that's why I think putting resources in the hands of clinicians, probably in the forms of a global budget, it's not perfect, but it's the best I can think of. I think that the price control issue that Dr. Leiter is asking about has to do with risk. And yeah, I think you'll find most people in the policy world I'm dealing with think that they're favorable toward, from one point of view, giving the clinicians control over budgets, over the money that they're going to then spend on patients. And it does involve some shift of risk. I trust the pay providers a lot more with that difficult job than I do the people who are there to serve their investors.
I've got nothing to add to that.
Thanks. So one other question that we had was, how do we message this to physicians and to the public? We've been using GREED. We're not quite sure if GREED resonates outside of our kind of progressive physician circle. So I'd be curious, Representative Oman and also Dr. Berwick, if you found some messaging works better than others to get folks on board, and what strategies do you find, especially across the aisle, seem to help move the ball forward?
This is a good question. This is a question we spent a lot of time thinking about in Oregon. And so we mentioned rural access a couple times actually, and I think the the useful thing in terms of messaging is making sure that our conservative leaning and Republican friends understand that um, if greed and sort of corporate decision making is guiding our healthcare system, rural areas are the first to get screwed because it's way harder to make money in a rural area in healthcare than it is in an urban center. So this is not a liberal versus conservative issue. I will say I think it's important in my state, for what I was trying to accomplish, I had to make very clear that this is not a single payer healthcare issue, which a lot of people, I think, make some assumptions, or are they trying, is this a Trojan horse of some kind when we're talking about CPOM? And the honest answer is it is not. That is a separate conversation. And it's a conversation that's happening in Oregon. We are actually, how we have committees and task forces that are exploring this. But to me, the messaging that resonates really strongly is who should be in charge of patient care? Do you want your healthcare controlled by a doctor, or do you want your healthcare decisions controlled by a corporation and some nameless, faceless private equity firm in San Francisco or New York? And that is how we tried to ask the question, is like, this is about control of medical practices and control of patient care. And that resonates strongly with people. And frankly, it's hard. What we found in our very long negotiations, which we've restarted after the session, is it's very hard for our opponents to answer. It's very hard for the people who want to maintain the status quo to explain in a public setting why a corporation should be able to control various aspects of a clinical operation. That's an uncomfortable conversation for them to try to have, to explain to policymakers why they need to be in charge of it instead of physicians. So I think physician control, physician independence, who's in charge of patient care, those are the kinds of questions that I think we should be asking. Dr. Berwick?
That sounds really right to me, and I think that I can see how that would resonate, and it sounds like a really strong answer to the question of communication. The other one I would put on the table is back to the Gallup poll I happened to mention, which I think is pretty accurate. What's being talked about at the dinner table about healthcare? And as I say, I think it's basically three things. I'm spending more and more out of pocket. Our high deductible plan, co-payments. Um, my employers, were unable to get wage increases because the employers got to put more into healthcare. So number one is you're worried about how much money this is costing you, not the nation. I mean, if you show up and say it's 20% of gross domestic product or double other countries, nah, it's not where people's heads are, but they are. We know that people are worried about costs and what's happening to them. Second, access. You can't reach your doctor. Your doctor's a great person, but you can't get through, or something's going on here where I can't see the people I really want to see. And then third is it's so complicated. I don't understand these words. I don't understand my bill. I don't understand, like, when I go up to the pharmacy desk, it looks like they got a roulette wheel that tells them what to charge me, because I certainly can't figure it out. I think if we could draw a line between the kinds of reforms we're after, uh, even at the level of individual initiatives like the corporate practice of medicine bill, and say, yes, we know this is troubling you, and it's going to continue to probably get worse if we stick with the current approaches. Here's some changes, and here's why those changes could improve your out-of-pocket costs, your financial risk, your exposure to medical debt. Here's how it can help you get better access to a doctor who cares about you, and here's how it can make things simpler. If we could draw that line, I think we got a case to make.
That's amazing. And I like those dinner table um, ideas. I wrote them down. So, and I wrote down a lot of what you said too, Representative Bowman. So again, always learning. I'm going to put the link to sign the Declaration Against Greed in Healthcare in the chat, and we are out of time. So if you liked kind of what you heard, please, please, please consider joining us. We are always open to new members. We also have a leadership conference coming up in Silver Spring, Maryland, right out of DC from the 5th to the 8th. There's still time to register. Just go to our website, doctorsforamerica.org. We'd love to have you there. And we have tons of other great sessions coming up in advocacy events. So if this is something that gets you fired up, then we'd love to have you join us. I'm always open to chatting about our work, and Angie Backey, our wonderful CEO, is also available. So thank you so much, Dr. Berwick, Representative Bowman. This was amazing, and we're just so appreciative that you took time out of your busy schedule. And please pencil us in for future events if you ever have the time. We'd love to have you back. So again, really appreciate it, and thank you to all our wonderful attendees. It was great to have you here.
Thanks for your leadership, Kate. Thank you.
Yeah, thanks for having us. It was great.
Of course. Everyone take care. Okay, have a great night.